Thank you. And I too would like to acknowledge the traditional owners of the land on which I and others are located at the present time, and express my respect for elders past and present. My talk today is about ethical issues in global health research. A big topic, and I'm going to move quite quickly, and I'll cover a wide range of complicated and sometimes intractable issues. Here's my declarations of interests. I'll draw particular attention to my roles in relation to global reconciliation, which we'll be talking about a lot, Praxis Australia, and my involvement with the Australia-Myanmar Institute. In fact, I'm going to start with the case of Myanmar to illustrate some of the very difficult, complex issues that we're going to be talking about today. Since the February the 1st coup last year, more than 2,500 people in Myanmar have been murdered, including many children. There have been well over 10,000 people, some say closer to 20,000, who've been arrested or disappeared. Up to 1 million have been displaced and are internally displaced people, or IDPs. There's many stories of torture, physical sexual violence. Villages have been bombed and burned. The health system has been targeted, especially doctors and other healthcare workers who have stood by their patients and the population. ICUs have been closed. Public health and vaccine programs have been stopped. Medicines and support systems are in short supply. As a result of this, everything you'd expect has happened. Endemic diseases are now rife. There's an absence, almost total absence of psychological services. And for the IDPs themselves, conditions are especially dire. In this setting, most of the NGOs that have provided humanitarian assistance to Myanmar have pulled out, and that's left just a few of them, but also the local ethnic health organisations, or EHOs, have stepped in, often at very great personal cost to themselves. Myanmar is a very beautiful country with an extraordinarily rich cultural history. This is the Shwedagon Pavilion in Yangon, which is one of the great cultural wonders of the world. This is Professor Raymond Pintway, an Australian psychiatrist of Burmese origin, who has worked tirelessly for democracy in Burma. This is from my last visit to Myanmar, just before the outbreak of COVID. This is in the Irrawaddy Valley, a situation of extreme poverty. This is one of the very few buildings that can withstand a flood, and it's a building that houses the animals, who are in many ways more important than anything else. No primary health care at all, no running water, no sanitation. The local businesses are really just dependent on local industry, and our health project sought to bring the people together in an evidence-based way to provide primary healthcare support and rudimentary educational services. This building was built by the people themselves with assistance from donations from Australia. Situation today is a bit different from that. The poverty remains, of course, but the violence is, as I've just described, almost unimaginable. The circumstances, not just in the cities, but in the villages, are especially brutal. This is a village that's been bombed by the military, with a result of massacres of large numbers of people. In that setting, we have proposed a research project, a project that we're yet to get underway, that is but I thought I would tell you a little bit about the proposal in order to illustrate the problems that arise in this setting, I think, reasonably vividly. We've called it Responding to the Health Needs of Internally Displaced People in Myanmar, and this is a proposed community-based participatory inter-country project to maintain humanitarian capacity in an evidence-based and accountable manner. This is, as you might see, an impeccably conceived project. Its aims are to develop educational, logistic and administrative infrastructure, facilitate effective responses to the needs of the IDPs in selected areas, to collect data about health needs, and to design programs and guidance systems to respond to them. How are we going to proceed? By close consultation with health providers in Myanmar, but also drawing on resources from Thailand and Australia, involving the ethnic health organisations and the IDPs themselves, developing a data collection process, identifying gaps in knowledge, deciding on particular areas of specific needs, developing response systems, and then moving ultimately to the active implementation of these programs. Clearly, as the project gets underway, there'll be a need for continuous collection of data and review, and that's all based on community consultation. Sounds easy, of course, but think of the context. These are the challenges. It's not so difficult to formulate an admirable sounding project that addresses a clearly definable need, but we have a cruel dictatorship, ongoing military conflict of the most violent kind. The junta itself imposes very strict internal conditions on movement and activities, especially in the health field. To be able to proceed, we need to be able to work not only with the junta itself, but also with the National Unity Government, the democratically elected government that was ousted by the military, the ethnic health organisation. There will be a requirement for clandestine cross-border transfers, especially from Thailand. There are huge risks to local communities and the local health providers. And we've worked with DFAT to try and conceptualise this. DFAT, I have to say, has gone hot and cold. There's a lot of ambivalence and uncertainty from the Australian side. And of course, there's the history of very limited Australian foreign aid commitment altogether. So how do you undertake a project in an area of huge need where we can understand what the problems are, we can formulate the responses, but getting it actually underway is not so easy. So I want to move now to talk about global health. If we're talking about global health research, we have to understand what global health itself is. Most people are familiar with the basic facts. 87% of the huge amount of money spent on healthcare globally is spent on a very small proportion of the world's population, the richest part. About $70 billion a year is spent worldwide on health research, but only 10% of the global burden of disease attracts the vast majority of this expenditure. The pharmaceutical industry is obviously an important player in health research everywhere. It's important in developing countries as well as in wealthy countries. The US market accounts for the lion's share, both of research and of sales and profits. Diseases such as malaria and tuberculosis attract very little attention in a research setting, and much of the focus and much of the profit comes from Me Too drugs, lifestyle drugs, drugs for the prevention of diseases that are prevalent in developed societies rather than those that are most in need. So this really tells us what the ethical environment of global health looks like. Here are a few things, and you can complete the list yourself. There are widening economic and social disparities. Rapid population growth is a major problem in some areas. Escalating ecological degradation, we'll come back to that. Internal social conflicts, local and regional wars, global contexts and conflicts, especially at the present time, the Ukraine war and other major conflicts on a global scale. The role of infectious diseases we'll mention again, and this has led to and will continue to lead to massive population shifts and dislocations, and we're familiar with the problems of refugees. I've mentioned IDPs, immigration, Aboriginal populations, and so on. And underlying a lot of this is the legacy of colonialism and the problems of foreign aid. I'll just mention very briefly foreign aid in order to get it out of the way, but because also it's so fundamental. Foreign aid, which we often refer to, is mostly neither foreign nor aid. In most cases, especially in the case of Australia and the United States, it's an arm of foreign policy that's intended to serve the interests of the donor countries. And often it's intended to do that at the expense of the recipient countries. And that's partly because of the role of ideology and culture, differences in attitudes to the family, community, political ideologies, and so on. I'm just going to illustrate this very briefly with some experiences from around the time of the tsunami in Sri Lanka. This is the sea from the view from the looking outwards from the northeast corner of Sri Lanka, a place called Mullaitivu. The sea looks absolutely beautiful and peaceful and placid. Wasn't so peaceful and placid on the morning of the 26th of December 2004, when the Indian Ocean tsunami occurred. There was a huge response in terms of humanitarian aid. Some of it was effective, but a lot of it wasn't quite what originally met the eye. If you walk through the forest inland from Batticaloa, you'll come across a number of signs like this: government of Sri Lanka, Germany, Asia Development Bank, the Netherlands, and so on. And you'll see some admirable buildings like this. This is a photo I took some months after the tsunami. Beautiful building. After the world press had gone and the visiting dignitaries and ministers, the place was left without, it was never fitted out. There were no doctors, and the place remains empty even to this very day. This is a village also inland from Batticaloa. It was 3 kilometres inland from the limit of the tsunami. This village itself received no aid whatsoever, whereas the neighbouring village became quite wealthy. That led actually to physical violence, a kind of minor civil war between this community and the one that they'd coexisted with for many years, only 3 kilometres away. This is Mullaitivu itself, a few weeks after the tsunami. This is what it looked like, absolutely complete destruction. This is Mullaitivu Hospital, which was run by one doctor who'd been there for 9 years, who'd worked 24 hours a day, looked after the population of 4,000 people, of whom many were actually killed. The situation was one where malaria was rife, there was obvious malnutrition. What foreign aid did they receive? The doctor himself showed us the foreign aid. It was 6 ECG machines, which he left unpacked, without unpacking them in a corner. So this is the story of colonialism and foreign aid. Okay, so let's switch to global health research. In this very complex and difficult context, we can understand that research has a really huge role. So, what is it that we try to do in global health research? Well, here's an attempt at a formulation. Global health research aspires to provide evidence to support effective strategies to support the health of populations around the world. But as we already know, and as I've already adverted to, health issues are multifactorial and many competing interests are involved. So what's the problem? How do we respond to the problems of increasing inequality and disadvantage arising as a result of the economic and cultural effects of colonialism, as well as those multiple other variables, some of which I've already referred to? So let's try and think about it in a little bit more detail. What is it that we're seeking to do? Well, here's a few ideas, and this is, again, not an exhaustive list. And in the research setting, we can try and understand what's going on. We can try and understand the social determinants of disease. We can try and understand the social effects and consequences. We can seek to build local capacity. We can aim to develop new pharmaceuticals, to develop the major responses to major health needs. We can develop and test infrastructure. We can seek to identify local conditions of illness and disease, test response strategies, local challenges, and we can aim to negotiate with involving local communities, the complex global and national political, economic and cultural environments. It's a big task, isn't it? Lots of things to do, a huge array of possibilities against so many overwhelming odds. So in this setting, there are lots of ethical issues that arise. This is the main slide in my talk, and I'll come back to it a few times. I've listed, this is not an exhaustive list either, of course, but I've listed a range of the ethical issues that we confront in the global health research context. On the left side, I've put some larger structural features, and on the right side, more specific ones about actual projects. I'm going to give you some stories just about a few of them, and so 3 of them in particular. We'll talk about politics and global health conflicts and the effects of globalisation, large-scale structural factors. There are cultural sensitivities and biases. The role of international funders that really appears in 2 ways as the potential conflicts of interest, but the international funders, which include private philanthropists like the Gates Foundation, really raise some serious problems, largely about whose view or whose ideology and indeed whose money might prevail. There are issues of equity and fairness and the need for engagement with governments as well as local communities. On the right side, there are issues that are largely familiar to all of us from our work with HRECs in Australia, issues about study design. I'll talk about standards of care, placebo research, and the others. Now, there are lots of frameworks to guide how we actually proceed in this area. There's the Nuremberg Code, the Declaration of Helsinki, our own national statement, and in most developed countries, there are regulatory regimes that refer to overseas aid or overseas research work, and within the countries themselves, there are often ethics committee systems, although these are somewhat uneven. The national statement, as usual, is completely exemplary and gives us guidance and sensible guidance in this area. When a researcher from an Australian institution proposes to conduct research in another country, there are additional ethical considerations. We have to express regard for the beliefs, customs and cultural heritage of participants, but to recognise values. Sometimes they're different from those of the national statement. Sometimes their intention with both our own values and maybe sometimes with the values of other countries. But the bottom line for us in Australia is that the standards that we apply can't be less than those that we apply in Australia itself. So let's try and think about it in a bit more detail. Let's start by talking about politics and global conflict and the effects of globalisation and structural factors. Obviously, you're talking about global health. You can't ignore the greatest global health challenge of our time, or one of the 2 of them. Climate change is one of them, and the other is COVID-19, and of course they're linked. We're very familiar with graphs, with the history, the number of deaths. Official number of deaths is said to be about 6.6 million. Most people accept that it's probably closer to 25 million. We're aware of the effects in India, in Africa and elsewhere. And there's a huge array of ethical issues that have become bread and butter for many of us here today over the last 2 or 3 years. I'm going to focus on the question of causes. Interestingly, and maybe astoundingly, the scientific response to COVID-19 quickly became highly politicised in a way that we're very, very familiar with. So we're talking about global health research, about research into the greatest global health challenge that we've been facing. The immediate claim from the American administration was that there was a lab leak from Wuhan, and this was the underlying cause. A lot of scientists jumped on the bandwagon, calls for international inquiries, and so on, and a lot of discussion in highly reputable journals by highly reputable scientists. And of course, this is not just a purely theoretical debate. It's something that really affected political discourses around the world, in the United States, in Australia, in Europe, and elsewhere, sometimes drawing out really unfortunate consequences. The scientists themselves went and did the work, and a lot of the work was led by the Australian scientist Edward Holmes, whose group did a comprehensive genomic analysis of SARS-CoV-2 and came to the definitive conclusion that there was no evidence that this virus had been genetically engineered anywhere, not in China, not in the United States, not in Europe, nowhere. And the two WHO inquiries have shown no evidence supportive of a lab leak from Wuhan itself. So we really, and many of the original scientists who jumped on the bandwagon later backtracked to some extent and said and recognised that in fact the original claims really had no basis. Added to that was really a generation of work that climate scientists have been telling us about for many years, and that is the forces that underlie the increasing risks of new zoonotic infections. And there's a mountain of work and a mountain of evidence, and many of them were really sitting back waiting for the new pandemic. We know what the effects of climate change are, and climate change and environmental destruction, and we've experienced them in Australia in very vivid detail: droughts, floods, wildfires, crop failures, increase in ocean levels, and pandemics. The COVID pandemic, like many of the new zoonotic infections that have arisen since the early 1980s, is a phenomenon of climate change. So, global health research, what are some of the questions that we have to ask at this very high level? Here's a few of them before I go on to my second story. What are the underlying forces that are generating the increasing numbers of zoonotic infections in the world today? And what can we do about them? What strategies are available? These are really questions for global health research. Why have the lessons of science, which have been known for a long time, been ignored or denied? And how did it happen that science and research became so politicised in this setting? And we can ask some questions about science itself here, and I'll just throw this in here, and I'd be happy to come back to it in discussion if you want me to. Does science actually serve inherent goals? Is it committed to certain ethical values, or is it just a servant or a plaything of the dominant regimes? I'll leave that as a provocative question. So story 2, let me talk about cultural sensitivities and biases. Here my example is what I'm calling sanitation insecurity. Now we know how important clean water and sanitation is. Sustainable Development Goal 6 is to ensure availability and sustainable management of water and sanitation for all. There's a lot of evidence in support of this, and I don't need to go over it in detail. WHO says over 1.6 billion people don't have basic sanitation services. There's a lack of household wastewater disposal system, very poor sanitation that's associated with multiple diseases, and this leads to a lot of health issues and social dislocation. A lot of evidence here to psychosocial impact, effects on children, women, maternal mortality, and so on. So what do we do about it? What are the responses? Sounds simple, build more toilets. The Indian government set out a policy of no toilet, no bride. Here's Narendra Modi visited Australia in 2018. There was a lot of discussion about this, and even Bollywood got in on the act. The World Toilet Day in November 2018 was part of an international campaign that really captured people's imaginations around the world. Figures are a little, as you can see, vary a little bit depending on which perspective you're taking, different from the WHO figures, but the message is pretty straightforward. The world, the wealthy countries need to contribute to building more toilets. Here's an artistic installation in the streets of Geneva, perhaps the most sanitised city in the world. People well-dressed, well-nourished were aghast at seeing this iconoclastic artistic statement that was really meant to draw people's attention to the urgent need, but also to the extent to which we can contribute by simply throwing money in order to build more latrines. But there's a body of research that shows that the cultural context of this is actually a little bit more complex than it first seems. Here's a rather remarkable article from post-colonial studies called The Cultural Politics of Shit, Class, Gender and Public Space in India. And it's so important that I'm going to actually read out these two paragraphs in detail. In urban centres, toilets are an expression of gender inequalities with severe implications for women's mobility outside the domestic sphere. In rural India, the No Toilet, No Bride campaign runs the risk of intensifying existing gender inequalities by closing off the limited access that women have to spaces outside the home where they can meet with, socialise with and befriend other women. Traditionally, many women in rural areas actively seek out public spaces such as the communal water tap, the river canal side, where they go to fetch water or wash clothes. The field and bushes where they relieve themselves serve as spaces for socialising with and befriending other women, at the same time as they allow them to escape the home, experienced as an oppressive space by many women. So things are not always as they seem. So in terms of the complexities raised by the cultural issues, here are a few more questions. We accept that the adverse effects of poor sanitation are well established, but the answer, as I said, may not lay in merely building more toilets, which many scientists and well-meaning humanitarian activists have advocated. How can we understand the deep complexity of the ecological system involving culture, gender relations, sanitation and public health? And what interventions can be developed and validated that simultaneously address the health issues, wealth disparities, gender power relations, and familial relationships associated with latrine adoption and use? It's a difficult area, isn't it? Now, my third brief story will talk more about the issues on the right side of this slide. In particular, I'm going to focus on standards of care, and I'll show you just a few pictures from a West Bengali village. The Declaration of Helsinki states that the benefits, risks, burdens and effectiveness of a new method should be tested against those of the best current prophylactic, diagnostic and therapeutic methods. This doesn't exclude the use of placebo or no treatment in studies where no proven prophylactic, diagnostic or therapeutic method exists, but really only in those circumstances. And at the conclusion of the study, every patient entered into it should be assured of access to the best proven prophylactic, diagnostic and therapeutic methods identified by the study. Sounds very noble, sounds very highly desirable. Once again, it's more complicated than it sounds. What do we mean by standard of care? Well, complicated idea. Standard access can refer to research funding, technology, medical care during the trial, follow-up, culturally appropriate resources, expertise, training, and other things. And there are expanded formulations that refer to culture, community consultation, social justice, and so on. There's no single clear definition of standard of care, and there have been raging controversies now for many decades that were especially sparked off in relation to some HIV studies. And debates still are focused on access to the best proven drugs, but of course the context, the needs and availabilities of treatment differ. So I'll take you now to a village called Radigi in the Sundarban area of West Bengal, down near the border with Bangladesh. It's a very poor town, but with quite a lot of people and a very vivid culture. Healthcare in India has really 4 levels. Private healthcare, which is similar to private healthcare in Australia. I'm not going to show you that here because it doesn't exist in Radigi. There are public clinics, and this is one of them. This is actually the consulting room, and this is about as private as it will ever get. There's traditional medicine and traditional healers. This goes back, of course, thousands of years, but there's limited evidence to support many of these treatments. Most of the burden of care, however, is undertaken by people referred to as quacks, not in a disparaging way necessarily. These are people with limited or minimal training who actually do most of the care. And this is a picture of a 1930s X-ray machine that the quack is using to X-ray someone who's fallen over. Who knows what the levels of radiation might be. And this is the Radigi Community Hospital. It looks idyllic. This is actually an algal growth over a pool of water that is a fantastic breeding ground for mosquitoes. Our project was in response to a gastroenteritis outbreak, possibly related to the sanitation issues. And this is really one view of the hospital ward overflowing. This is what the standard of care in Radigi Hospital looks like. There are no nurses, but the mother's the nurse. There's no food services. The family has to provide them. There's in fact no mattress covers. And of course, there are no pharmaceuticals. This small child is lucky, or perhaps we might say unlucky, to be receiving an intravenous infusion, but that's not the case for most people. So this is the standard of care. In Australia, we know what to do to respond to childhood diarrhoea. In Radigi, it's more complicated. So here are the questions that arise in relation to the standard of care. Whose standard of care should apply? Why test a treatment that's state-of-the-art if there's actually no chance that the people in the target population could ever gain access to it? And does the Helsinki Declaration's noble insistence that the best proven prophylactic diagnostic and therapeutic methods protect human rights, or is it just another example of misguided Western cultural imperialism? Okay, let me just in the last few minutes draw a few conclusions and ask a few additional questions. I'm not going to recapitulate my entire talk, of course, or try and summarise, but I've made a few basic points. Global health is a complicated idea. It's an uncertain concept, and it's subject to lots of different forces, influences, and variables. Global health research operates within this field. It's a contested conceptual and practical field, and it's subject itself to multiple influences of a scientific, cultural, economic, and political nature. So as a result of this, the ethical challenges are multiple and sometimes seem intractable. There are large-scale structural questions that relate to politics, global conflicts, structures of inequality, and so on. And there are the specific details of how we actually go about responding to the need in the local environments. Now, it hasn't been the focus of my talk, but I don't want to leave you without some sense that there are ways in which we can respond here. And there are some high-level approaches or principles, not necessarily about the content of the projects themselves, but about the way we actually do business as global health researchers. We can approach the issues with humility, with introspection, with a commitment to social justice, with a respect for local knowledge and cultural systems, and we can engage in dialogue with community members, policymakers, government, and others. Doesn't give us the answers, of course, but at least gives us a method of working. And here's my last slide with a few questions that I think have come directly out of this talk. What do we do about it? How can we, as global health practitioners and researchers, support the people of Myanmar in their struggle against tyranny and oppression? What do we have to do in order to prevent another pandemic? How can we counter misinformation and untruths, including those from the scientists themselves? How might we contribute to addressing the problems deeply enmeshed in historical structures of culture, politics, and gender? And what's our role in relation to the efforts of local communities to overcome inequality, poverty, and political oppression? With these questions, I will end this talk and leave you to respond. I'm looking forward to the discussion that follows. Thank you very much for your attention.
Thank you, Paul. We have no questions from the audience today, so I think I'll ask one myself. I've always wrestled with the notion of how do we get beyond our cultural biases, and how do we know what an appropriate approach is, for example, to local culture. I'm thinking of female circumcision, which is rightly considered genital mutilation. Is that a cultural aspect we have to respect? And thinking back in time, I've done a lot of research on the Tuskegee syphilis study, and the investigators in that study thought they were doing good, thought they were providing the best, most ethical research possible. And we look back and see that that was not the case. So are we stuck in the contexts of our upbringing, our own cultural biases?
Okay, that's a great question, Hudson, that raises quite a number of issues. And I guess at one level, those of us who are health practitioners in Australia are very familiar with the problem of engaging with people who may not share our social, political, or ethical views, let alone our cultural or religious perspectives. And that's the job of the health professional in general. In the global health setting, of course, this becomes much more difficult and complex still. And especially as I've mentioned, the systematic context of the relationship between the global north and the global south, and the history of colonialism, of the cultural and economic destruction associated with Western colonialism, and the ongoing hegemonic relationships between the developed world and the developing world greatly complicate this question even further. When we think about particular cultural practices, we may well have very strong views of our own. You mentioned female circumcision. and global, which you referred to as genital mutilation. And clearly, it would be very difficult to find someone in a Western country who would defend female circumcision or one of the practices associated with that. But even there, that's a more difficult question than one might imagine. And the stories about the responses to that are actually quite interesting. Maybe I'll tell you just a couple of those. The first is that the underlying process of recognising the role of genitals, the cultural role of genitals, is obviously not limited to women. So the practice of male circumcision goes back a very long time, and it's not, whilst there is sometimes a controversy about it, there are many people, it's the view of the paediatric profession in Australia, that male circumcision serves very little medical purpose. There are many people around the world who still strongly support it. So clearly there's a cultural investment in attaching certain meanings both to the male and female genitalia. And it's within this context that one has to understand the practices that are undertaken in relation to girls and women. In some countries, there have been efforts to shift that process by developing a new kind of celebratory process that doesn't involve mutilation itself. In Malaysia, for example, there's been a campaign to recognise and valorise the female genitalia, but without a major intervention. And some paediatricians have really championed the idea of a celebration that involves actually raising a small drop of blood rather than doing something more aggressive or mutilating. So the idea is really to shift the ritual or the tradition in a way that preserves the traditional values, but also is consistent with more contemporary health practices. I was involved some years ago in relation to a different practice in Zambia, where there is a tradition that if the husband dies, the surviving wife may have sexual intercourse with the husband's brother. This is a polygamous society, polygamous Christian society. And whilst that might have, the original practice might have supported the welfare of the surviving wife in the age of HIV, where the husband has died of AIDS, mandating a sexual relationship between the wife and the husband's brother is obviously not a good idea. So there was a major campaign by the government in the 1990s to shift this practice so that instead of actually engaging in sexual intercourse, there could be a sexual contact where the wife sat on the lap of the husband. It was actually had a name. It's called sliding, and it caught on, and it was recognised as a valid cultural process that recognised, acknowledged, and respected the traditional values of the community, but adapted it in such a way that it maintained safety in the age of a new health threat, which was HIV. So this again shows the complexities associated with global health and the kind of interventions we need to make. Of course, it's the role of global health research to collect information and data in order to test these innovations, to ensure that they do two things: that they really do respect the traditions and they're accepted by the local communities, and also that they protect the health and safety of the people involved.
Thank you. Do you think there would be merit in requiring all global health researchers to form interdisciplinary teams with economists, social scientists, other than traditional medical or public health researchers, or in addition to?
That's another interesting question, and the short answer is yes. Of course, it has to be interdisciplinary, and it's important for those of us working in the field of science, but to be modest about the limits of our discipline, and to recognise that the values that we approach, and these are not just the cultural values, but the epistemological values, are ones that are in fact subject to a cultural history and cultural variation, and that when we enter a new society where the worldview might be completely different, what we take for granted may not be accepted. Certainly may not be accepted as true, valid, or obvious. So as practitioners, we need to be open to other disciplines, other ways of thinking, and for that we need to be able to call upon people with the appropriate and relevant expertise. So in that setting, social scientists, political theorists, anthropologists even, maybe economists, as you say, may well provide a really important and critical input into the work that we do. The sanitation security or insecurity issue is a really good case in point there, because that became a huge global movement that attracted large amounts of money. And there were many people, particularly young people in Australia, who were very, very committed to World Toilet Day and to donating money to build new latrines and so on, without really an understanding of that really deep complexity of what it actually means in a local village in India. It's not just a matter of throwing money and building new latrines. It's a matter of working with local communities to understand their issues, and this involves multiple disciplines, multiple ways of thought.
I can remember in the early days of the HIV epidemics, even in Western countries, my first experience working with cultural anthropologists was an eye-opener. These people taught us, public health people, many things that we thought we had the scene covered on, and we didn't. Next question. How can we carry out ethically appropriate research and interventions in locations that are closed to outsiders? You mentioned Myanmar, but Afghanistan and North Korea would be added to that list as well.
Well, and lots of other countries, of course. Well, that's a big question. That's why I started with Myanmar, really. How do we do it? We do it at risk of our own lives. I've worked quite a lot in Gaza and the West Bank, as well as in Israel and in Syria. And they're very difficult countries to work in. And maybe I'll just mention Gaza briefly here. As we well know, Gaza has been the subject of a very bitter conflict for a very long time. To get into Gaza itself is quite difficult, because one has to travel and across the world and then negotiate permits from the Israeli government and then move through all sorts of security checks and so on. And then within Gaza itself, there are risks of violence, both from internal forces and also the conflict with the Israelis. So the people of Gaza are deeply traumatised. There are huge health issues. It's said to be the most densely populated area in the world. So how do we operate? What is it that we have to offer in this setting? And I'll just say one thing there, and that is travelling to Gaza. As I kind of emphasised how difficult it is to get there. It takes like 2 days. One has to be stripped naked as one goes, or nearly naked as one goes through the checkpoints and so on. And one can sit in a room and then have a conversation and conduct seminars about public health research and study design and so on. they have good internet in Gaza, and it's possible that one can conduct these sorts of sessions online, just like we're doing now, and one can have these conversations, or one can go through that process of actually travelling across the world and being interrogated, of waiting for days at the border and so on, and then one sits in the same room with the people and has exactly the same conversation. But it's not the same conversation, because actually to go there and be in that room and to demonstrate that level of commitment and to engage personally with the people who are grappling with those issues themselves is a mark of solidarity, it's a mark of generosity, it's a mark of support, and it offers something quite different from simply providing information over the internet. So I'm not really answering your question, but I am making a point, and that is that in engaging with these difficult areas, whether it's Myanmar, North Korea, Gaza, Syria, or elsewhere, it is actually important for us to go there, to be with those people, to share their pain and suffering. And that in itself provides some a significant input of its own. It's not just about throwing money at a crisis. It's about engaging with people, about working with them, about listening to them. And hopefully it's also about doing what I'm trying to do now, and that is to share some of that knowledge with other people back home. I've learned much more from my travels and my work in this area than I've ever been able or would ever be able to teach anyone. And so one of my obligations, I think, is to be able to share that knowledge with other people. So these are complicated processes of dialogues, of sharing knowledge, of being able to change the way in which we do business around the world, of engaging with people who are living in very difficult circumstances.
If I, as chairman of an Australian Human Research Ethics Committee, receive an application from researchers who want to do research in a country which has no ethics review process, how do I approach that? What yardstick do I use?
Yeah, it's a brilliant question, and there's no simple answer. The national statement in section 4.8, as I was talking about before, gives us some guidance, and the guidance, as I said, is admirable and sensible and true, and we do need to follow that. And that is to recognise that that there are standards that we have to apply in Australia, and we should seek not to compromise those, but we need to be sensitive to the values, attitudes and practices of people in those other countries. We need to find ways of consulting with the local communities. We need to satisfy ourselves that we're not engaging in a neo-colonial or imperialist ideological project, but that we're really working in genuine dialogues with those people. There are no precise tests. There are no algorithms, no protocols that apply here. So the ethics committee really has to go back to first principles, the principles that I've just talked about, and assure itself that the researchers are acting in a way that's appropriate, with adequate humility, with adequate respect for those local communities. Research is important, and just because a country is poor and doesn't have an ethics committee doesn't mean that they don't need to undertake health-related research. On the contrary, it's arguably more important in those contexts. So there really is a critical need for these kinds of activities to take place. And as I said a minute ago, these are important sources of cultural dialogue, of actually sharing knowledge and bringing back that knowledge and information and those insights to our own society so that we can share them amongst ourselves. So it's an important activity and we need to support it. So the HREC needs to start from the premise that this is a good thing in principle, but the practices have to be thought out in relation to the local contexts.
And there's a follow-on to that, how do we assure ourselves that we're linking in with the appropriate cultural context? And what is the appropriate cultural context, as opposed to the one that's politically dominant or most vocal or receiving most public attention at the time?
Yeah, again, these are great questions, and they're all completely true. And the answer's implicit in the question, and that is that we don't know. We can't be sure, and we can never be sure. I mean, look at current events. Look at the massive information about COVID-19. Look at the massive information about the Ukraine war, where no side can be trusted. How do we actually piece together what the truth is from the multiple sources of information, none of which we trust? So this is the problem of the contemporary world, and particularly with the dissemination of information around the internet. This is really why I referred to the debates about the origins of COVID. There was a lot of information, not just about the origins, about treatments and vaccines and other things. How is it that we actually come to make a decision about what's valid and true, about who the authentic spokespeople are, about whom to trust? That's the same when we actually visit a local setting. If I go into Gaza, there are multiple people there. There's the local political groups. There's Hamas and the groups that are opposed to it. There are health practitioners. There are economists. There are all sorts of people, and they have multiple views. How is it that I decide who it is that I think is really telling the truth? There's no simple answer, and I guess there's never been a simple answer. It's a problem of philosophy and science in general, that it's part of our roles as professionals, as practitioners, to be able to sort through the massive information and data and to try and make decisions for ourselves. Now, we can perhaps try and speculate about how we actually do that, what standards we apply, what criteria we use to try and recognise what claims or what kinds of data seem to be reliable, and what ones that we reject. But here again, there's no simple algorithm. There's no protocol.
I'll ask you one more. Is there any way that we, as public health people, as ethicists, can persuade organizations like, let's just take an example, FIFA, to benefit poor, suffering people when they have a vested economic interest that has nothing to do with that in a country like, let's just say, Qatar?
Maybe this is a good question on which to end the session. I guess my answer is we've just got to keep trying. This is the story of our lives. And this is not just, it applies to the health system in Australia, it applies to the social environment in Australia, but also internationally. There are huge vested interests that are there to support their own purposes, and they have their own entrenched systems of values. And it's our job to try and struggle to change that, to dislodge that. The odds are great, but the stakes are great too. Climate change, war, nuclear holocaust, and so on. These are the threats that we face. It's our job to do what we can to try and avert those disasters.
Thank you, Paul. I'll end not with a question, but a comment from several of our audience. Everybody's looking forward to your next book.
Thank you, Hudson. Thank you to the questioners. They're wonderful, perspicacious questions, and I really appreciate them. And I've enjoyed this discussion. Thank you so much.
Thanks all.